Okay. Good evening, everyone. I'm Dr. Howard Rappaport at Sioux Falls Health. I am the dental director for our Sioux Falls dental residency program and head of faculty. And I want to welcome you to our uh, Sioux Falls Health and Delta dental education series. Few items before we get started. Please, all participants, stay on mute. We do encourage questions for tonight's speaker, Dr. Anuja Doshi, through the Q&A box, and all questions will be looked at, addressed at the end of the presentation. Um, be sure that the Zoom display name is your name, and so that we can verify your attendance in the webinar to receive the CDE credit. Please remember to complete the evaluation at the end of the presentation. The link to complete that evaluation will be posted to our continuing education page, the CDE page at zoufallhealth.org/CDE. The evaluation is open for 1 week following this evening's presentation, and certificates usually arrive at the participants 2 to 3 weeks later. You'll also find links to register for upcoming courses at Sioux Falls Health. You can register for our future courses by visiting that page. Again, zoufallhealth.org/CDE. We can also display our past courses here. After the course ends, you will find a survey below Dr. Doshi's name on our CDE webpage. Again, the evaluation will be open for 1 week and your certificate will be sent to you in the following 2 to 3 weeks. So now I'll turn this over to our dental director, Dr. Jade Duncan. She has some information that she'd like to present to you about Sioux Falls for anyone who is new to our organization. And good evening and have fun.
Thank you so much, Dr. Rappaport. Like you mentioned, I'm Dr. Jade Duncan. I am the Senior Vice President of Dental Services here at Sioux Falls. And a little bit about Sioux Falls. Sioux Falls Health is a federally qualified health center in Northwest and Central New Jersey. We have been serving patients for over 30 years, and we were founded in 1990 by Dr. Bub Zufall and his wife, Catherine, pictured here in front of our dental office in Dover. In 2023, we treated more than 48,000 underserved patients across 7 counties in the state. We want to give a big thank you to Delta Dental, our CDE series sponsor. They have been a longtime partner of Sioux Falls, supporting clinical operations in our very early days to our Sioux Falls Health Delta Dental mobile unit, as well as our Smiles for Our Heroes event that provides dental services to low-income veterans. They have been supporters to our new clinical space in West Orange that opened last year. So here are some of our oral health initiatives. We have this CDE course that you're joining on now. We also have a community dental health coordinator program that trains professionals to help patients navigate the dental healthcare system. And we have our dental assistant on-the-job training program that provides on-the-job training to participants right here at Sioux Falls to help us address critical gaps in the dental workforce. Finally, we highly encourage you to save the date for the Beyond the Smile Symposium this November. It will be November 15th, and registration will be open very soon in the next week or so. So how can you get involved with us? We have a few opportunities for how you can get involved with Sioux Falls. We always welcome your financial support. You can make a tax-deductible contribution to us through our foundation at zoufallhealthfoundation.org/donate to support access to healthcare for our underserved patients. And next year, we'll be looking forward to you to volunteer as a provider once again for our Smiles for Our Heroes event. And you can always reach out to AFAF, whose email is on the registration link now if you're interested in participating. And now we'll proceed with tonight's course presented by Dr. Anuja Doshi, who I'll briefly introduce. Anuja Doshi, DDS, is a diplomate of the American Board of Periodontology and a fellow-elect of the Royal College of Dentists, Canada. She is an assistant professor and the director of DMD Periodontics at the University of British Columbia, Vancouver. Dr. Doshi's commitment to advancing periodontal education has earned her recognition from the American Academy of Periodontology and the AAP Foundation. Notably, she was honored with the prestigious Dr. D. Walter Cohen Teaching Award in 2019 and the Excellence in Teaching and Mentoring in Periodontics Award in 2020 and in 2024. Dr. Doshi currently serves as the chair of the American Dental Association section on periodontics. Dr. Doshi, I'll now turn it over to you. Thank you very much.
Thank you so much for that great introduction, and thank you for inviting me. I'm truly honored to be here and spend this next 1 hour with everyone. Share my screen. Oh, it's not letting me share my screen. But since I have a couple minutes. No, again, thank you everyone. I see people up from all over North America, so thank you so much. I hope you can get something out of this today, and feel free to ask questions. I also have my email and Instagram listed, so you can reach out to me through either of those platforms if there's something you want to talk about. Lauren, can you help me here? Because I can't share my screen.
Yes, I can hear you, Dr. Duncan. I don't have, I don't see that I'm the co-host. I contacted Lauren.
Okay, I guess I'm gonna get started until we figure out the screen sharing, but I'm gonna at least talk about just some of the learning objectives for today. So I'm gonna start with like talking about the components of the periodontal phenotype versus peri-implant phenotype. Then we'll move on to understanding the impact that periodontal phenotype can have on your overall tooth health, and the same thing for the implants. What is the impact of soft tissue peri-implant phenotype on health? And then eventually we'll talk about phenotype modification surgeries, when are they indicated, and what do they look like. I believe I should be able to share now. Oh, yeah, there we are. Okay, I think we are good to go. Perfect. So yeah, like I was saying, my email and Instagram is listed here, so feel free to reach out to me if you have questions that we don't get to today at the end of the session. So I already mentioned with the learning objectives. So, okay, I'm gonna get pretty much start here. As we all may be aware that there was a big transformation in the periodontal world when it came to the classification. There were a lot of updates, a lot of changes. I won't get into the big change that the staging and grading and the periodontal diagnosis part of it. But one of the changes that also came around in the consensus report was the term gingival phenotype. For the longest time, we were using the term biotype and not phenotype. So before I get into the full meat of the presentation, I'm going to really get into the definition. So what is phenotype, and why did we move from biotype to phenotype? So phenotype is any observable characteristic that you see in a person or an animal or anything, right? Like anything, like the color of the eye, the type of hair you have. These are observable set of characteristics, and that is your phenotype. So it's a combination of both your genetics and the environment can have an impact on it. Versus biotype is only related to genetics. So you can't modify someone's biotype. But phenotype, on the other hand, can actually be modified through environmental influences. One of the classic examples of that is flamingos. I don't know how many people know. I know when we think of flamingos, we think of them as pink, but they're actually white. Flamingos are genetically white, but because of the environmental impacts, which is their diet, is what actually makes them pink. When they consume shrimp diet is what makes them pink. So there's a change in that observable characteristic because of the environment. And that's like the easiest way to understand what is phenotype. So we are going to get into first the components of periodontal phenotype. The first part of that is pretty straightforward. Everyone knows the width of keratinized tissue from your gingival margin to your mucogingival junction. That's your keratinized tissue width, and that's pretty standard. So that's the first part. Then is your gingival thickness. Now, this is probably something we are not routinely measuring day to day. You probably are looking at the width of keratinized tissue. You're obviously doing pocket depths, but you're probably not looking at gingival thickness or actually measuring it. So I'm going to quickly touch upon that. So gingival thickness, broadly speaking, is really of two types. You have your thin or thick. So we call it thin when you put a periodontal probe, and you can pretty much see through, and I'll show you what that looks like. So if you put your periodontal probe, and if you're in the marginal gingiva, if it's pretty translucent and you can almost see your periodontal probe through the tissue, that means your gingival thickness is less than 1 millimeter. So it's thin phenotype. Versus if you have thick phenotype, it's when your gingiva is more than 1 millimeter, so that when you put your periodontal probe in, you can't see it through that marginal gingiva, and that really makes it thick. This is like sort of the easiest way to determine if someone is thick versus thin. There are a little more nuanced methods to do that, but on a day-to-day sort of routine clinic, this is the quick way of testing someone's gingival thickness. So with that being said, that's the second component of the periodontal phenotype. And then the last one is the alveolar bone thickness. And this is like three-dimensionally, not just the buccal or the lingual side. Every site of the tooth, what is that alveolar bone thickness? And all these three together make the periodontal phenotype. However, today we are going to only focus on the soft tissue phenotype. So that's your gingival thickness and the width of keratinized tissue. So I won't talk a lot about the bone. On the peri-implant side, there's a little bit of overlap in terms of the components of phenotype. So the first part is, again, the similar. We have the mucosal margin and the mucogingival junction that gives you the width of keratinized mucosa around an implant. We don't call it gingiva around an implant because the soft tissue component around implants look different from your teeth, and I will talk about that towards the end. But one of the key differences is that your collagen fibers are not inserting in; they're just running parallel through that implant. So we call it the mucosa. But you also, backwards. The next part of the peri-implant phenotype, and that's more unique to implants, is the supracrestal tissue height. That is essentially from that mucosal margin to the bone crest. And that thickness has a pretty significant impact on long-term peri-implant health, the crestal bone, and we'll get into all of that. But that's the second component that you have to keep in mind. And again, it's a soft tissue component. The third is mucosal thickness, similar to the way we have gingival thickness. It's the same thing. You can have thin or thick tissue thickness around an implant. And then it's your peri-implant bone thickness. Again, it can be buccal or lingual, but that's also one of the components of a peri-implant phenotype. But talking about the soft tissue part, we have three components when it comes to peri-implant, which is mucosal thickness, a width of keratinized mucosa, and then your supracrestal tissue height. All right. So before we get into the rest of the presentation, one last definition. So what is phenotype modification therapy? This is a term that you'll probably come across more, and especially in the more recent literature, because we've started using it more now, and especially since we went from biotype to phenotype. This has become a more common terminology in the periodontal world. So periodontal phenotype therapy is any therapy that surgical intervention that you're that allows you to modify any one of these components, whether you are talking only the soft tissue, whether you're only doing the thickness or the width of keratinized tissue, or you're doing all of it. You're going to modify the soft and the bone tissue volume. That's going to all be included in phenotype modification therapy. So like I said, today we'll talk about phenotype modification therapy as it comes from the soft tissue aspect, but you can also do modification by changing that bone thickness. When I think of, again, relating this back to the flamingos, it's the same thing. I think of them as getting therapy when they're going and eating on some shrimps. That is their phenotype modification therapy. That's essentially what's happening when they're feeding on certain diets. So what I've done with this presentation is I've taken some of the most frequently asked questions that I get, all the FAQs that I get when it comes to soft tissue and a periodontist. Like if whether it's from my dental hygienist, from my general dentist, my students. So what it will help you do is that it will probably answer some of the questions that you might have, but it will all tie in together really well at the end. So just follow along. So the first question that we all always get, and I'm going to step into, is gingival recession. So I'm going to start with something very simple. That, okay, when should we treat recession? Does every recession need to be treated? When do we refer a patient with gingival recession to a periodontist if it needs treatment? So the best way to evaluate that is multifactorial. It's not a single answer that, okay, every recession needs treatment. It does not. So there's a lot to it. So the first is, of course, patient's concerns. If your patient does have concerns like aesthetics and root sensitivity, that is one of the times, yes, we'll consider treating the recession. But there are other ways to treat that as well. So there's always an approach which does not involve surgical intervention. So you can also consider that. But then, so it has to be beyond that. It can't just be patient concerns. What else is going on? If your recession is active, if it is something that you can actually see it changing over time, that's definitely one of those times I want to jump right in and do a surgical intervention, because an active recession that is clearly progressing over time is likely to keep progressing, and then it's harder to treat once it gets more severe. So those are definitely one of the scenarios where I will recommend a patient to get surgery sooner than later. But the other key ways where a periodontist will look at is in terms of determining whether, okay, should we wait, should we monitor, should we jump in right now, is some of these factors. And what is the depth of the gingival recession? If it's more than 3 millimeters, you are starting to reach that danger zone. So you want to treat it. Along with that, is there something else? Like, is the lack of keratinized tissue width? Is there a high frenum attachment or thin tissue phenotype, a combination of these, all of this? If I see a combination of this, that's a definite treatment recommendation. Like, that's definitely something I want to treat. That's definitely something I will let my hygienist, the general dentist know that please refer that. It's also easier to treat it for us when it's not as deep or it's about 3 millimeters, and then it gets harder to treat from there. We'll also talk about some of the restorative orthodontic side of things. Okay, when do we jump in if the patient is referred to an orthodontist? So I will get into that. But this is sort of an overview, okay, when you should consider treating recession. So what is the consensus on how do we treat recession? As of now, the gold standard approach of treating gingival recession is still autogenous graft. So we like to take patients' own tissue, and we call it the connective tissue graft, with a coronally advanced flap. That's like the gold standard. For years and years, we've tried and tested everything else. This still works the best. There are alternatives to autogenous grafting where you can use donor tissue and they work. I'm not going to say they don't, but it's still not considered the gold standard. So if the goal of treating the gingival recession is root coverage, that you want that exposed root, you want to cover that, then the treatment should be a connective tissue graft for the coronally advanced flap. So I'll show you some examples. So this is the same patient, and she was fairly young. And this was forced orthodontics. She developed recession. It's always, again, like as a periodontist, I love treating, doing plastic aesthetic surgery on someone that is on the relatively younger side, because you can almost always guarantee a good healing outcome. So this patient, we did a connective tissue graft right here. You can see the graft tucked in under the gingiva, and then it's sutured right over. There were more sutures after this, so I haven't included all of that. But if you have good blood supply, someone just that overall good inherent potential to heal, connective tissue grafts can heal really well. And that's just my own validation. But they can heal really well. The tissue blends in really nicely, and it almost looks like you never had a graft or any surgery. And the healing time can be pretty great too. If the patient has quick healing response, then it can be a pretty short healing time. So again, you can get great response with connective tissue graft. It doesn't, not only do you get complete root coverage and you can predict that, you can also get that gain in width of keratinized tissue. So it actually changes your phenotype to an extent, along with getting that root coverage for recession. That was a single rooted tooth. You can also have multi-rooted teeth that you can, again, do the same thing. You just would need a larger connective tissue graft. This is, again, someone that had multiple teeth recession. We tunnel it, essentially. So we like release that flap, put the grafts in, get nice passive closure, coronally advance the flap, and it's sutured up here, and then you can get pretty much complete root coverage. Again, that increase in width of keratinized tissue, you will observe that over time. You may not see it immediately, but you definitely increase the tissue thickness, and then you get root coverage. So the other common question I get is, so what if I don't treat it? Like, what if we leave it as it is? We don't do anything with our gingival recession. So then it is, we have enough evidence to now support the statement that your gingival recessions, and they've looked at more buccal than the lingual, but buccal gingival recessions will continue to progress over time. Again, doesn't mean you have to jump into surgery right away if you don't have some of those other factors that we talk about. But if your patient asks you, okay, what if I leave it alone? You still have to let them know that this will likely progress over time. And we can monitor it, but over the years, it is likely going to progress. And especially if it's associated with lack of keratinized tissue, or you have that high frenum attachment or thin tissue phenotype, that's more likely to progress over time and more susceptible to attachment loss over time. And lastly, it does increase your susceptibility for root caries. So one of the things that I never like telling my patient is that, oh, if you have recession, or even if they have deep recession, I will never say, well, you can lose the tooth, because that's inaccurate. There's no evidence to support that statement. But what is true is that, yes, you can get root caries, and then that could make the prognosis hopeless. And that could eventually result in tooth loss. But the recession itself, yes, will progress, but you can't make the claim that it's going to lead to tooth loss. I don't like scaring my patients like that. So moving to the next component, then what is the consensus on the treatment of lack of keratinized tissue? Or do we jump in every time we see lacking keratinized tissue? So according to the World Workshop that was done by AAP in 2015, they did come to the consensus that as such, we don't have a threshold amount of width of keratinized tissue that we need to maintain health if the patient has optimal plaque control. Now, obviously, more often than not, we don't have those patients that are on top of the oral hygiene or have that optimal plaque control. But if they do, then yes, you can, if a patient, for example, like right here, presents with lack of keratinized tissue, we can monitor that. But if they don't have adequate plaque control, then the minimum amount of keratinized tissue that we want is at least 2 millimeters. The more, the better, but we want at least 2 millimeters to maintain health, to be able to prevent further recession or formation of new recession. So then that is that golden number, 2 millimeters. So how do we treat lack of keratinized tissue? One of the again, the gold standard method of treating lack of keratinized tissue is a free gingival graft. So this is still an autogenous graft. This was a harvest taken from the patient. I don't know if you can tell, there are 2 pieces of grafts here that have been sutured together. So it was a bilateral harvest from the patient's palate. Not fun for the patient, but that's one of the again, the gold standard ways of treating. If your goal is to increase the keratinized tissue, if you don't really care about the root coverage and you just really want a nice thick band of keratinized tissue, then this is the gold standard. So you can see the before and after. Now, like I said, that you don't expect root coverage, but we did get pretty significant root coverage in this patient. Even though that's not what we expect, or it's not, we will always warn the patient that what I'm doing here is going to make your gums look nice and thick. It will prevent further loss, but I may not be able to bring everything back up. But sometimes we get lucky and we get this really nice root coverage with a free gingival graft. But this is what a true phenotype modification looks like, because not only have you increased that one component, the soft tissue, the width of the keratinized tissue, but you also increase the gingival thickness substantially. So you have gone from a thin phenotype to a thick phenotype, and you've also increased that width of keratinized tissue. So that is your gingival phenotype modification surgery. I wanted to show one more example. So this is someone that presented with, as you can tell clearly, a very shallow vestibule right here, and I hope you all can see my arrow. The gingiva was almost like at the level of the lip. So we would pull on the lip and would pull the gingiva with it. She obviously had history of periodontal disease. She has had attachment loss. She's a relatively old patient. So again, the goal here was not try to bring all of this back. Root coverage was not even an option. This was just to give her some keratinized tissue and increase that vestibular depth so that she can maintain health for at least a few more years. So that's just, as you can see, you can fairly make out the outline of my graft. This is about 8 weeks after healing. No, actually, this is 6 months after healing, and she clearly was due for a prophy. But again, you can see the difference it can make in changing the patient's phenotype. Even though here we were not expecting root coverage, because you take away that pull from the lip, your tissue will snap back. So you get something called as creeping attachment. So it will start to coronally advance a little bit, not a whole lot, but you'll get a little bit of more attachment than you would expect it. So that patient's always like that. So like I said, free gingival graft is the true gold standard if your goal is to increase keratinized tissue or deepen the vestibule. There have been long-term studies that once you do a free gingival graft, that's never going anywhere. It is going to stay for life. That will only look better over time. It will keep maturing, but that width of keratinized tissue that you gain from a free gingival graft stays like for life. Like there's nothing, and if only it gets better over time from the creeping attachment. Untreated sites that have been sites that have lacking keratinized tissue and or gingival recession, they do continue to progress, or you will find new areas of recession developing in areas lacking keratinized tissue. So this has all been shown in long-term studies and recent systematic reviews. So the next question, I think, and this is something periodontists and orthodontists, we go back and forth on in terms of when is the best time to intervene for someone that is going through orthodontics. Do we do some sort of soft tissue modification before, after, during, and is it beneficial? So this was a patient that that was referred because she developed this recession towards the last part of her orthodontic treatment. So we treated right before the braces were coming out with a free gingival graft. And again, young patient, we got great root coverage, even though we didn't 100% expect that. But again, we increased that width of keratinized tissue, increased that tissue thickness. But I will say, though, that this is, of course, not always the scenario. It is much harder to treat someone who's had orthodontics and now not only has lost tissue, but has also lost bone potentially from that arch expansion. So then it's really hard to get complete root coverage or be successful with phenotype modification surgeries. Like I'll give you this example. So this was, again, someone that had orthodontics and was then referred because of the recession she developed after. If you look at it from the frontal view, it looks pretty like a straightforward recession, that high frenum attachment. But if you look at it from the occlusal view, you can see how labially inclined that root is. And that's what makes it really challenging to treat. I often joke with my students, it's like when you've had a big buddy toe and you have a buddy toe belly and you're trying to pull your pants up and they keep wanting to roll down. That's what we are trying to do. We are trying to pull the gingiva really up, but it's not going to want to stay there because it's a really overextension of the over contour of that root that's in your way. So we do some odontoplasty at the time of surgery, but there's limits to how much we can do that on a root surface. But with this patient, we did 2 rounds of soft tissue grafts. And again, we didn't get 100% root coverage. But as you can see, we gained a lot of keratinized tissue. We eliminated that high frenum attachment, improved that overall tissue quality. So again, this doesn't always work with every patient, especially if the arch expansion has resulted in that roots really getting out of that arch. So some of the recent studies have shown that orthodontics patients are very likely to develop gingival recession in anywhere 2 to 5 years, especially if someone has thin tissue phenotype. Because what we found now is that when someone has thin tissue phenotype, the underlying bone also tends to be thin. And that's what eventually leads to recession because now you lost the bone and the tissue. They have also shown that, okay, if someone has thin tissue phenotype, both the tissue and the bone volume, and then you're going to do arch expansion that's going to push the teeth outside the bony housing, then that is very likely going to result in recession. So now, especially with the digital technology we have and with Invisalign, we can even play with that. If we already know that we are going to push this and we have a CBCT, we can very accurately, I wouldn't say very accurately, but we can get an accurate estimation of, okay, is this likely going to result in recession? So we can intervene before you even start orthodontics. And that's easier for the patient, it's easier surgically, and you can prevent the recession from forming in the first place. So I just wanted to show you what someone with thin tissue phenotype can look like under the underlying bone. So they're more likely to have dehiscence and fenestrations everywhere versus someone with thick phenotype is more likely to have bone that looks like that. So even if you don't have CBCT, if you see someone with thin tissue phenotype that clearly has really thin tissue, and they're going to get orthodontics, which is likely going to be an arch expansion, then you might want to consider intervening before you even start ortho. So one of the, I won't get too much into this, but I don't know if everyone's heard of this, but one of the other ways to sort of combine the two, your ortho and perio, is to do surgically facilitated orthodontics. This is not my case, but I've done a couple of these. They're not always popular with my orthodontic colleagues because, again, it involves convincing the patient to go through surgery, and which obviously they may not want to, they may not be compliant with. But essentially, the concept is that you do a phenotype modification. But whilst you're doing that, whilst you're adding a bone graft, a soft tissue graft, you decorticate the bone. So you make cortications in the bone. So put it in a remodeling process so that can accelerate the bone movement. So that can accelerate tooth movement within the arch. There is, again, I won't get into, there's a little bit of controversy in terms of how much acceleration you get there, but this is one of the ways where you can intervene, and then peri-ortho can collaborate together and allow for more accelerated orthodontics and preserve the bone and tissue. Again, this is something it's not recommended for every patient, but if there is already, if this is adult orthodontics and you have thin tissue phenotype, then that is one of the ways you can consider not only like changing the patient's phenotype, but it could also help the orthodontist in that accelerated movement. So it helps everyone. So to wrap up this part, does phenotype modification therapy contribute to maintaining periodontal health? That's the sort of the million-dollar question, right? So again, going back to sort of what we talked about with lack of keratinized tissue, periodontal health can be maintained even in sites that have thin tissue phenotype, thin tissue, as long as there is good oral hygiene and there are no iatrogenic factors. So there's no restorative margin that's getting too close to the gingiva, or there's no orthodontics that we are talking about, then yes, we can maintain. So that doesn't, so just because someone has thin tissue phenotype, I'm not going to recommend surgery. So it always has to be a combination of factors, the thin tissue phenotype with recession, lack of keratinized tissue, that's when it becomes indicated for surgery. But again, knowing that it is more likely to turn into recession, anyone with thin tissue phenotype is more likely to develop recession. And that is something we do have to warn our patients. I'll always show my patients a mirror and show them what I mean by the thin tissue and how they should be more careful and how we need to monitor that. And if we see any signs of recession or progression of recession, then we are going to intervene. Again, like I was saying, currently there's no evidence to support that we need to jump into surgery just because someone has thin tissue phenotype, unless there's an associated mucogingival deformity or gingival recession. There has been studies to show that when we did intervene and did phenotype modification surgeries, that gingival thickness as well as the keratinized tissue that we gain from the surgery, you can use that as a predictor for long-term health. So once you gain that, you can pretty much be sure that this is going to be stable long-term. So essentially to say that yes, phenotype surgeries work, and they don't just work in the short term, they work in the long term, and it'll be almost like a one and done procedure in those terms. So the patient won't have to keep going back to getting that surgery in a few years. It's your free gingival graft, or even if you do a soft tissue graft where you increase that gingival thickness and increase that keratinized tissue, that's going to stay lifelong. And it's same, like I said, this follow-up studies are done for over 10 years. One of the sort of the predictors that we use in the peri world is after we do any surgery, whether it's connective tissue graft or free gingival graft, the sort of the timeline to know, okay, has this worked and is this going to stay long term, is a 6 months. We recall the patients at 6 months. That's when you want to check the two things. You want to check if you have at least 1.5 millimeters of keratinized tissue that you gain from the surgery and a thickness of about 1 to 5. So essentially your probe, you shouldn't be able to see it. If you have that, then that pretty much tells you this is now going to stay long term. So that 6 months is when your tissue is mature enough to make that judgment call that, okay, that's it. We don't need to do anything further. The other advantage of phenotype modification surgery is that when you also include root coverage, it does reduce the long-term risk of non-carious cervical lesions. So NCCLs are, not only do you reduce them, but you also prevent formation of new NCCLs. And this study that particularly looked at the long-term follow-up for 30 years, looked at free gingival grafts, that whenever a site was treated with free gingival grafts, not only did it prevent the ones that existed from progressing, but it also prevented new NCCLs from forming. So that prevents your long-term risk for root caries. So that's the other advantage of phenotype modification surgeries. So I'm going to quickly wrap up so then we can move on to peri-implants phenotype. So probing depths will always be greater when patients have thick gingival phenotype because your tissue doesn't shrink easily. So that inflammation, even if you treat it, you don't get that shrinkage. So they tend to have deeper probing depths. But on the other side of things, when someone has thin tissue phenotype, they're more likely to develop gingival recession, and which is likely going to progress over time. We can maintain health both with thin tissue phenotype and with lack of keratinized tissue if the patient has optimal oral hygiene and there's no other iatrogenic factors. In the absence of oral hygiene, we need that minimum 2 millimeters of width of keratinized tissue. And if you do have thicker tissue, mucogingival surgeries or phenotype modification surgeries are more predictable versus if your tissue is also really thin, because that does affect the blood supply. But those are normally the sites that are indicated for surgery. But for most parts, your autogenous grafts will work really well, both as a connective tissue graft or a free gingival graft. All right, so moving on to the importance of peri-implant phenotype. So like we discussed, there are those 3 components. So I'm going to first start with the 2, the thickness and the width of keratinized tissue. And then finally, we'll talk about the supracrestal tissue height. So until 2017, if you looked at all the data or the consensus reports that came out in terms of how much keratinized tissue do we need around an implant, it doesn't matter. Can we maintain health without adequate keratinized tissue? Unfortunately, until 2017, we couldn't come to consensus. There was literature to support both. There was enough literature to support that, well, you can maintain health without any keratinized tissue, and then there was literature to support that no, we need at least 1 to 2 millimeters of keratinized tissue. But that was 2017. In the last 7 years, there's been a lot of new evidence that has been published. Some of them are long-term studies, and there is a lot of evidence to now support that lack of keratinized mucosa around an implant is going to be associated with peri-implant mucositis and crestal bone loss, both of which, again, correcting for that keratinized mucosa is much easier than having to deal with any sort of peri-implant disease, as we all know. Studies have also found that, especially if your patients are not compliant with maintenance, which most of my patients are, even if they're getting a single implant, most of them will get that 1 implant and then they don't always show up for the maintenance. So I pretty much presume all of my patients are going to be erratic with the compliance. So for me, it's always no question that I'm going to always have 2 millimeters of keratinized mucosa around an implant. Like that's the sort of the standard we follow, and that has become the standard of care. If you ask anyone that's going through implant training or residency right now, we want that 2 millimeters around an implant because prevention is so much easier than having to deal with it afterwards. And it's also much easier to intervene whilst we are doing an implant surgery anyway. So that 2 millimeters for implants has pretty much become the standard of care, and with all the evidence we have right now. So the consensus report from the osteology workshop had also concluded something very similar. This was in 2020 or 2021, I believe. They essentially said the same thing, that if you have lacking keratinized mucosa width, it's going to be associated not only with increased inflammation and plaque formation, but there's also increased patient discomfort. And I do get that complaint fairly often whenever I have patients with lacking keratinized mucosa or implants. That is a complaint that patients will talk about, that when I brush, I'm really sore there, or when anything touches it, I'm really sore there. So not only, even if the tissues are not inflamed, this is just from the fact that the tissue is so thin, and if it's lacking keratinized tissue, just the fact that it rubs against the implant surface or that thin bone underlying it is what's making it, it's causing the discomfort. There's also association with increased marginal bone loss and then prevalence of peri-implantitis. So again, instead of trying to correct for it later, it is a lot easier for us to just add it as a part of our treatment plan when we are treatment planning implants. So when do we treat it? If the patient already presents with an implant, so if I see less than 2 millimeters of that width of keratinized tissue along with any one of these, then I definitely recommend surgery. If the patient only has lacking keratinized mucosa and has had an implant for many years, then we'll just monitor. But if they complain of pain or soreness in brushing, because that means they will not be able to maintain their home care. If there's recurrent inflammation, history of peri-implant mucositis, and of course, if they're not compliant, then those are all the reasons that you might want to jump into surgery. And this is also supported by the osteology workshop in 2022. So this is again a patient that had implant-supported overdentures and clearly lacking that width of keratinized tissue and really thin tissue phenotype. Out of the 4 implants, 2 on the top, 2 on the bottom, there were just 2 implants that were really sore for her, and the other 2 did have more keratinized tissue, so we only treated 1 on each side. Then we took a really large, nice big grafts. I like to put that in there. I like big grafts. And then we split that into 2, and then we did it as we would do a free gingival graft. And then that's the healing afterwards. So again, you can get all that really nice chunky tissue there along with that increased width of keratinized tissue. We didn't expect to get root or sort of implant coverage here, but we did get some if you compare it to before. And then it pretty much drastically improved patients' comfort at home when she was brushing and when she was wearing the dentures. We, of course, relined the dentures and made adjustment to her over dentures as well, because probably was also, there was a pressure point there. But just changing that tissue phenotype can have pretty significant impact on that patient's discomfort from brushing at home and maintaining home care. So just doing the phenotype modification surgery with a free gingival graft, or there are other substitutes, does it contributing to maintaining long-term health? Some of the recent evidence and more long-term follow-up studies have sort of supported that yes, not only can you get significant reduction in inflammation, in patient's discomfort, and improvement of the dehiscence and overall aesthetics, but you can also maintain this without changing the bone. So say, for example, this patient, from her radiographs and obviously clinical evaluation, her interproximal bone levels, or pretty much the mesodistal bone levels here, were pretty good. The implant was well osseointegrated. So there was no reason for me to go in there, first modify the hard tissue, then change the soft tissue. It wasn't needed. And studies have shown that as long as you modify the tissue and change that tissue phenotype, you can maintain that long term. You can maintain stability. You can prevent recurrence of inflammation without needing any surgical intervention on the hard tissue aspect of it. Even if there is an actual existing bone dehiscence, you can just modify the tissue and you can maintain health, which is what we do for a lot of patients that have had implants for many years already. So we don't try to jump in and change all of the bone. As long as you maintain healthy tissue level, you can maintain health long term. The other time, this is a patient that I placed the implants, and at the time of implant placement, they needed a bone graft, so we grafted. I already was aware that she doesn't have enough keratinized tissue as I would like on the buccal aspect. So like I was saying, it's really easy to do the surgery when we are doing a second stage surgery of placing the healing abutment. So at the time of healing abutment placement, we place that pre-gingival graft, so that sort of outlines it, and you can almost see the graft healed up there. So it modified that tissue in terms of the tissue thickness, increased that keratinized tissue. It also contours the tissue really nicely and almost gives you that really nice thick width. And I know this is going to stay for her long term. This was an implant that I like to always say, hashtag not my implants, because I didn't place these implants, but these implants were placed by another surgeon for an implant supported overdenture. And then once it healed and the patient started wearing a regular dentures, she complains of pain. And then obviously they looked at it and they saw these ulcers. The surgeon wasn't quite sure what happened there and why this tissue looked the way it is. So they were worried it was peri-implantitis. We took radiographs and we did clinical evaluation. It didn't look like an active inflection. It did look like that it had sort of created that traumatic ulcer from just not having adequate keratinized tissue and having really thin tissue there. It was a little concerning because these implants were a little buccal than I would have liked them to be. But she was 80 years old and we were not going to jump into a full guided bone regeneration. So we were like, okay, let's modify your tissue and then we'll take it from there. So again, just a feature of a graft, and this is the after. So you can see the before and after. So sometimes really just modifying that tissue can like do wonders for the patient without intervening. Again, the implants are well osseointegrated. So we told her we monitor, and of course, if the dehiscence or if we saw attachment loss on that buccal aspect, then she would potentially need a bone graft. But for now, I think we could maintain health just with the soft tissue modification. So studies have also looked at, okay, what if you how does thickening up that tissue, like changes in mucosal thickness affect long-term health? And they have shown that you will have less marginal bone loss over time. So saving that crestal bone loss, preventing crestal bone loss is really the key to like maintaining long-term health, because once you have crestal bone loss, it starts to be downhill from there. So if you can do anything to prevent that in your treatment planning of the implant, as well as soft tissue volume changes if needed, then again, we are definitely recommending that, because it can affect your long-term implant health. So the last components that we'll talk about is the supracrestal tissue height. Almost to wrap up. So I want to quickly talk about the supracrestal tissue height. Is a relatively new term, and we now have something called supracrestal tissue attachment, which is essentially replaced biologic width. So this is that distance from, again, your mucosal margin to the bone crest, and it's typically not attached around an implant, which is why we don't have healthy probing depths around implant. Your implants can probe 4 and 5 and 6 millimeters and still be held, because there is no connective tissue attachment in that supracrestal tissue height. If you compare a tooth versus an implant, this is always going to be a more taller component. In tooth, we all know we roughly estimate it to be about 2 millimeters. For implants, it's typically going to be 3.5 and above. And that's what the ideal is. We want that. We want that at least 3 millimeters of supracrestal tissue height. The reason is they've looked at, again, for long-term studies, whether you have a thick supracrestal tissue height naturally, or if you from surgical intervention. In both those cases, your crestal bone levels can be maintained much better long-term if you have that at least 2 to 3 millimeters of supracrestal tissue height, as opposed to if you didn't. So if you have really thin tissue above your bone crest, it is likely going to result in that bone loss and crestal bone loss, which eventually could turn into full-blown peri-implantitis. There's more to this than just the tissue height. It's called the supracrestal tissue complex. So there is your contour angle, your emergence profile, emergence angle. So it is, yes, the tissue thickness is one aspect of it, but the way your restorative component emerges from the implant also affects your crestal bone levels. So it is multifactorial. But the more we are studying this, we are realizing how important the supracrestal complex is in the long-term peri-implant health. And this has been shown regardless of the type of implants you place, or whether you even incorporate platform switching and try to change that platform switching versus platform matching. It is really critical that your depth of the implant either naturally gives you that 3 millimeter of supracrestal tissue height, or you account for it by adding a soft tissue graft. But I will say, though, that more often than not, I see implants being placed too shallow. So you could have anyway had a taller supracrestal tissue height had you just placed the implant deeper. And unfortunately, somehow, I guess this becomes one of those things in implant dentistry that is less understood or less focused on. Everyone thinks about, okay, the bone quantity all around the implant, but we forget about this soft tissue component and the depth of the implant placement. So to wrap up the importance of peri-implant phenotype for implants, like I said, we have enough evidence to support that thin tissue phenotype and lack of keratinized mucosa, that is less than 2 millimeters, are significant risk factors. So we should be more proactive about that and treat them ahead of time, or especially during implant planning if we can. Implants should be placed, as everyone says, like as deep as necessary, but as shallow as possible. This is very, very true. I think, like I said, like, implants tend to get placed more shallow instead of being placed as deep as necessary. But that also does not mean we go all in and place them really deep just so that we can get like 4 or 5 millimeters of supracrestal tissue height, because that's also not always needed, except for anterior implants. And again, if you do increase that soft tissue volume through one of the surgeries, it does improve all the components, the inflammation, patient's outcomes, as well as aesthetics, and it can be maintained long term. Overall, so I'll just leave this part here that, like, as we participants might know, that of course implant planning, it's a lot more complex, and I tell this to my students as well. It's not just drilling a hole and placing it. So it's not, and it's not just looking at the bone. It's also looking at the soft tissue volume. So if you have to think of not the immediate outcome, but what this implant will look like 10 years from now, and we have to plan also accordingly. I like to end with this: that with great power comes great responsibility. Anyone in the chat can tell me who said that. You'll get extra points. When I last time I did this presentation, a lot of people didn't know who said this, if I can see it. But anyway, this was Spider-Man, Uncle Ben from Spider-Man. So yes, if you're practicing implant dentistry, definitely consider understanding the soft tissue components as well, and not just the hard tissue volume. And of course, make the referrals at the right time, incorporate soft tissue grafting if it's needed at the time of that implant planning. Unless you're my cat, then he gets all the power and no responsibility. I'm going to actually end here so that we can get some questions.
Okay. Dr. Doshi, do we have a moment for questions?
Yes, sure.
Okay. That first case, lower anterior, where you had just a single tooth recession, what do you suppose the etiological factor was? And can that factor affect your treatment's success?
Let me share again. What do I get out of my, sorry. If you're talking about the first single recession, the lower anterior, that was post-orthodontics. Again, I believe the patient had crowding, so there was some arch expansion involved, and she presumably had soft tissue phenotype to begin with. So when they did the arch expansion, that one tooth and even the lateral next to it had mild recession, but this one developed more recession. And then of course, brushing habits could be a part of it, but because she didn't have recession anywhere else and was really localized, and she did have recent orthodontics, that's what we concluded that's what the etiology was, because her oral hygiene seemed to be fine and she clearly didn't have recession anywhere else. And sorry, was there a second part to that question?
Can you hear me?
Yes.
Yes. Okay. My next question is, when's the best time to refer a patient with a thin soft tissue phenotype or inadequate keratinized mucosa at a site planned for an implant?
So that's a good question. Typically, if you look at the studies have looked at this in terms of the timeline of that approach, whether we should do a soft tissue graft when we are preparing the site for the implant. Do we do it at second stage surgery, or do we do it after the crown placement? So they've looked at multiple time points. The two best time points are either before you even place the implant, you modify the soft tissue before even your implant surgery, or you do it at the time of healing abutment, so your second stage surgery. Those are the only two time points that is the ideal time to do a soft tissue phenotype modification, whether it's just increasing volume or increasing keratinized tissue. The worst time to do it is after the final crown has already been placed. So that's not ideally, so which is why you want to be proactive and do it before the final crown goes in.
Okay, I think we have time for one more question. All your surgical procedures utilize host donor tissue. Can you comment on the use of dermal matrix for use in gingival grafting? And is there evidence to show that a dermal matrix is as effective as host donor tissue?
So it's not as straightforward. So first I'll start with saying that yes, it is effective and it works, and we have studies to support that. So obviously when autogenous graft is not an option, either because my patient denies it or they don't want their own tissue, or there's any other reason, for some medical reason, for whatever reason, if I can't get a tolerance graft, then yes, we use donor tissue. The sort of the downsides of those are that it almost becomes more technique sensitive to use them than not, because it doesn't have its own natural blood supply, and you get more swelling when you use donor tissue. So there are those factors that are involved. So there's a lot. So when we are planning, if it's multiple teeth recession where we are going to need a really large autogenous graft, which may not be possible, not ideal to put the patient through that kind of harvest, then we definitely move forward with a donor tissue, and it works well. But we just have to be more careful in terms of our final suturing. We also have to do a different set of prescriptions to make sure it doesn't have a lot of swelling. So it's some of those considerations. But the short answer is yes, they can work. I think someone else had their hand raised. I guess Scott or Valerie, did you guys have a question? Okay, I'm going to allow Scott, if you.
I'm sorry, I was been on mute. As a reminder, you must take our survey to get credit for tonight's course at zufulhealth.org/CDE. And thank you again for your attention. And thank you so much, Dr. Doshi, for an amazing presentation.
No, I'm glad. I hope everyone, like I said, took home something from this. But yeah, feel free to reach out to me on social media or email if you have questions. Again, I did try to allow Scott to talk, but I don't know if it helped. So if you want to ask questions right now, you can.
Okay, well, I think we have time for one more question. When doing the gingival grafting with the patient in braces, do you ask the orthodontist to stop all active orthodontic forces on the teeth that will be grafted?
Yes, so if it's during orthodontics, just for the 6 weeks of healing time, at least after the initial healing is completed, we will have them not do any active movement at that time. And like that one case was different, but if it's nearing the end of orthodontics, then we'll just prefer to do it after, because obviously anyway, oral hygiene maintenance is harder, and then you put a graft in and you have sutures there, so it can be quite messy and get inflamed really easily. So ideally we want to then just wait after, but if we ever do it during, then it's about 6 to 8 weeks when we'll wait to make sure we've had that primary healing.
Thank you. Okay,
Yes.
I think that's going to have to wrap it up for tonight. And again, thank you so much for your presentation and being part of our CDE
Oh, of course.
series.
You're welcome. Thank you. Thank you so much.